This is an overview of an article entitled Clinical Outcomes and Sustainability of Using CYP2C19 Genotype-Guided Antiplatelet Therapy After Percutaneous Coronary Intervention, published in the April 2018 issue of Circulation, Genomic and Precision Medicine. Clopidogrel is the most widely prescribed P2Y12 inhibitor following percutaneous coronary intervention, or PCI, to prevent platelet aggregation and reduce the risk of major adverse cardiovascular events, including stent thrombosis. Clopidogrel is a prodrug that requires biotransformation by Cytochrome P450, or CYP, enzymes, most notably CYP2C19, to generate its active metabolite. Here's a visual representation of the metabolism of clopidogrel, yielding an active metabolite via the action of CYP2C19 and an active metabolite via an alternative pathway. CYP2C19 loss of function, or LOF, variants are common in the population. Pharmacokinetic and pharmacodynamic studies show that loss of function variants are associated with lower active metabolite levels and a diminished antiplatelet response. Multiple retrospective analyses have demonstrated a significantly higher risk for major adverse cardiovascular or cerebrovascular events after PCI in clopidogrel-treated patients carrying one CYP2C19 loss-of-function allele, also known as intermediate metabolizers, or IMs, or two loss-of-function alleles, also known as poor metabolizers, or PMs, compared to clopidogrel-treated patients without a loss-of-function allele. Given the lack of prospective clinical outcome data, there remains considerable debate and uncertainty surrounding whether clinical CYP2C19 genetic testing should be routinely used to guide antiplatelet therapy selection in PCI patients. An increasing number of institutions are implementing CYP2C19 genetic testing. However, data are limited on the feasibility, sustainability, and clinical impact of using a CYP2C19 genotyping strategy to guide P2Y12 inhibitor selection following PCI in real-world clinical settings, as opposed to expensive, rigorous, randomized clinical trials with strict inclusion and exclusion criteria that might not reflect real-world practice. In 2012, the University of North Carolina implemented an algorithm incorporating CYP2C19 genotyping in antiplatelet therapy selection in high-risk patients, defined as having an acute coronary syndrome or high-risk coronary anatomy. CYP2C19 genotype testing was ordered at the interventional cardiologist's discretion and then performed clinically on-site using PCR-based methods, which reported the presence of the CYP2C19 star2 and star3 loss-of-function variants within 24 to 48 hours. In the paper under discussion, the authors sought to 1. Determine the frequency of CYP2C19 testing and use of alternative P2Y12 inhibitor therapy, such as Prasugrel or ticagrelor, in CYP2C19 intermediate metabolizers and poor metabolizers over time. 2. Identify the factors that influenced CYP2C19 testing and P2Y12 inhibitor selection. And 3. Examine the relationship between P2Y12 inhibitor, CYP2C19 status, and clinical outcomes. This single-center observational cohort included 1,193 consecutive adults who underwent PCI. Data was manually abstracted from the electronic health record. This figure shows the study population by CYP2C19 genotype and the antiplatelet agents prescribed. Of the 1,193 patients who underwent PCI, 868, or 73%, were genotyped. 30% of the tested patients carried one or two loss-of-function alleles and were more likely to be prescribed Prasugrel or ticagrelor. The authors also examined factors that led to the selection of Prasugrel or ticagrelor following PCI. Clinical factors, including an acute coronary syndrome or ACS indication for PCI, left anterior descending or LAD artery stent, and Prasugrel or ticagrelor use upon admission were also significantly associated with Prasugrel or ticagrelor selection after PCI, whereas elevated bleeding risk and clopidogrel use on admission were significantly associated with clopidogrel selection after PCI. The authors then determined whether the CYP2C19 status modified the association between certain clinical factors and antiplatelet therapy selection. In the graph on the left, they showed that the association between ACS indication for PCI and Prasugrel or ticagrelor selection was not modified by CYP2C19 status. But as shown in the middle graph, the association between elevated bleeding risk and a lower likelihood of prescribing Prasugrel or ticagrelor was more pronounced in patients without a CYP2C19 loss-of-function allele compared to IMs and PMs. The interaction p-value was 0.023. In the graph on the right, the association between LAD artery stent placement and Prasugrel or ticagrelor selection was only evident in patients without a loss-of-function allele, with an interaction p-value of 0.009. Clinical outcomes were evaluated in 999 patients with follow-up available after the index PCI. The graph on the left demonstrates that CYP2C19 loss-of-function variant carriers treated with clopidogrel exhibited a significantly higher risk, a more than threefold increase in risk of major adverse cardiovascular or cerebrovascular events compared to loss-of-function variant carriers treated with alternative therapy. Compare the red and black lines. In contrast, no significant difference in major adverse cardiovascular or cerebrovascular events was observed in patients without CYP2C19 loss-of-function variants treated with clopidogrel relative to alternative therapy. Compare the green and blue lines. The middle graph shows that there was no difference in the risk of developing a clinically significant bleeding event across the CYP2C19 variant and antiplatelet therapy groups. The graph on the right shows that in patients with an ACS indication for their index PCI, the risk of adverse events was highest in the CYP2C19 loss-of-function variant carriers treated with clopidogrel, the red line, consistent with the overall study population. The frequency of CYP2C19 testing and use of alternative therapy in loss-of-function variant carriers varied significantly throughout the study period. The graph on the left shows that following a very high rate of genotyping during the initial 6 months, 88%, the proportion genotyped decreased during the subsequent 12 months, 61% to 65%, and then increased to 78% during the final 6 months. The graph on the right shows the frequency of ticagrelor or Prasugrel prescribing. The frequent use of alternative therapy in CYP2C19 loss-of-function variant carriers, shown with the red bars, during the initial 6 months, 83%, was sustained during the subsequent 6-month period, but declined to 54% before increasing to 68% during the final 6 months. Use of alternative therapy in patients without loss-of-function variants, shown with the blue bars, was much lower. What are the clinical implications of this study? First, clinical implementation of CYP2C19 genotyping to guide antiplatelet therapy following PCI is feasible in a real-world setting. CYP2C19 testing was frequently ordered and used to guide P2Y12 inhibitor therapy. Second, consistent with previously published observational studies, this study found that clopidogrel use in CYP2C19 loss-of-function variant carriers was associated with a higher risk of major adverse cardiac and cerebrovascular events, with more than 3 times the risk. Third, the use of CYP2C19 testing waned over the time frame of the study, implying that sustaining this type of intervention in clinical care can be challenging. Finally, this study illustrates the need for the development of new strategies aimed at sustaining genotype-guided prescribing interventions over time.